Good morning, everyone. Let's turn the cameras on. How's everybody doing?
Good.
Good.
Good? All right. I'm glad to hear that. Everybody, all of you still trying to open eyes? Is it too early? Yeah.
Not used to being here at 9 o'clock on a Thursday.
But look, it's something better, right? You didn't have to get up early and drive to the school. Right? It's
Yep.
something positive.
Yep.
Excuse me. Okay. Still showing a few students absent. Bella, Olga, Nabila, Therese, Jerry, Trina, Kristen, and Rabia. Any of you here?
Good
I'm
morning,
here.
Professor. This is Rabia. I'm here. I'm just driving back home. I'll be home in 2 minutes. If you can please check me in right now.
Sure.
Thank you.
Okay, anyone else? Sorry, who was it?
I just scanned it. It's Cherry.
Okay, Cherry, thank you. Let's give it another minute or so. Anybody having any issues to join or anything? One of you please drop the text for these students. So Bella, Olga, Nabila, Therese, Trina. These are still showing absent. If your cameras are still off, please turn them on. Abhijit, for some reason I don't see your camera on. It looks like you're in dark mode again. Munir, Amir, Kristen.
I just need a few minutes.
All right. Kristen and Amir, please turn your cameras on.
Just one more second, please.
Okay. Kristen, can you hear me? Kristen? Okay, guys, if your cameras are not on and you're not responding, you are absent. You're not present here. So if I'm calling your name and you're not there, and clear means you're not there. So please make sure if it's your lecture time, you make yourself available. Lecture only. Okay, Lee, last name Lee. Shahina, I don't see your camera either.
Oh, my camera is on, Professor.
Why don't I see you? That's weird. Now it is.
Working now?
Yeah.
Okay.
Okay, I'm not sure if something going with Kristen. I can't. see, is any of you see Kristen on the camera? Anyone? No? All right, then let's move on. Let me see. It's still showing up. So. You guys have any question before we start the lecture? Okay, I still have Bella, Olga absent from the class. Okay, guys, let's move on. Okay, I believe we have 3 chapters for today's lecture.
Professor Olga messaged you that she was going to be late today.
Okay, thank you. Nothing from Bella? No. Okay. Guys ready? Yes? No? Okay, guys. So the first chapter of the day. These are acid controlling drugs. Now, when we talk about acid, we usually talk about antacids, correct? But here we are using more broader term, acid controlling drug, because we'll be talking about different type of drugs to help your patients who are experiencing too much acid, right? Acidity symptoms. So we'll go over the acid reflux, the acidity issues, and the solution, the drugs used, and then any adverse effect, interactions. One basic thumb rule I want you all to remember: do not give ever any other drug along with antacid, ever. The reason, the antacids will reduce the amount of drug absorbed. So the therapeutic action will be lower, a decreased therapeutic efficacy of the drug. So never ever get them close, separate them. And then we'll talk about important aspect developing the nursing care plan while your patient take these medications. So first of all, before we move forward with the solution, let's talk about the problem. Acidity or acid-related issues, right? So here we are talking about too much acid. We have to have acid. Acid is required, but when it's too much, more than required, that's when the problem comes, right? So these disorders that are associated with, like stomach and upper GI tract, when there's imbalance between the production of the gastric acid and the protective mechanism, which prevent damage to the stomach lining. Oh, I forgot to ask you. You guys see my full screen? You see it? Okay.
Yeah.
Okay. All right. So acid is required, but when it's too much, now it can damage the lining inside. Okay. Oh, sorry. Okay, Bella, I'll check you in. Okay. Excuse me. Now, there are different conditions, um, such as GERD, the gastroesophageal reflux disease, PUD, which is your peptic ulcer disease, gastritis. Now, what happens is the gastric acid secretion, the gastric acid, which we're talking about here, the HCl, hydrochloric acid, the parietal cells in the stomach lining, they are the one who release gastric acid. And the three factors which control its production, the HCl production, acetylcholine from the vagus nerve. The number two is histamine on H2 receptors, and gastrin, which is a hormone produced by G cells. So they stimulate the proton pump, also called hydrogen potassium ATPase, or just remember the proton pump, which is in the parietal cells. They release the hydrogen ions into the stomach, and which contributes to acidic environment, which is required for digestion. Then, on the other hand, there's a protective mechanism, and the stomach has several protective mechanisms to avoid any kind of damage to the stomach lining due to acidic environment, too much acid. Okay, there's a mucus layer which coats the stomach lining to protect it from acid. It's like how to protect your skin from sunlight, right? You wear the sunscreen, right? It's a protective layer. So same way, the mucus layer coats the stomach lining and protects it from damage. Then there's bicarbonate. Bicarbonate is a base. Remember, when there's too much acid, you need base to neutralize it, and that's what it does. Okay, and then there are prostaglandins. They promote the mucus and bicarbonate secretion, technically inhibiting the acid production. Okay, pepsinogen, that's an enzyme. It's a precursor to make the pepsin, which is an enzyme and required to digest the proteins from whatever the food you eat. Okay. Then their intrinsic factor, these are responsible for absorption of vitamin B12 from your food. If somebody lacks that, you have to supplement vitamin B12. Mucus we talked about, these are we talked about. So here it looks like, this is the zone we are talking about, the gastric zone. This is the pyloric zone, this is cardiac zone. It has nothing to do with your heart. The only thing related to cardiac in the cardiac zone is that it's in that area close to heart. That's why they call it, but there's nothing relevant to heart itself in there. But this is what we are focusing on, gastric zone, which release acid. Which one? Hydrochloric acid. Okay, where it is in? Parietal cells. Parietal cells are the ones who are responsible to secrete hydrochloric acid. Okay. Now here's another picture. Shows the gastric glands here. The parietal cells, which release acid, and then their chief cells, G cells. So going over a few of them real brief. For example, your parietal cell. This is what we're focusing here. It releases hydrochloric acid and their intrinsic factor, which help in absorption of vitamin B12, and then ghrelin, which is your hunger hormone. Okay. Now, mucus cell, it secretes mucus, and as we just talked previously, that it makes a protective lining inside the stomach. and prevent damage from hydrochloric acid. And then regenerative cells, they make new ones, replacing the old ones, the dying ones. And chief cells, they are the one who produce pepsinogen, which is an inactive precursor to make pepsin. And it digests proteins when activated by hydrochloric acid. And then your enteroendocrine cells, they secrete gastrin, which stimulate acid production, and also other hormone secreting cells, which are involved in regulating digestion. Okay, this we just covered. Let's talk about now the HCl. Okay, HCl, hydrochloric acid. Once again, it is released from parietal cells. What does it do? Why do we need it? Well, it activates pepsin, right? Converts pepsinogen into pepsin, which digests protein. That is one role. Then it breaks down food, mechanical and chemical breakdown of food. That is number 2. Number 3, it also kills the pathogens. It is a body's defense mechanism as well. So it provides a highly acidic environment, which means a low pH, which destroys harmful bacteria and microbes which are ingested with food. So if somebody who's not making enough acid, if the acid is low, okay, that is also risk. The patient can get infections quickly. And final, it helps in absorption of nutrients, iron, calcium. So it is required for digestion and maintaining a sterile environment in the stomach as well. Okay. And whenever somebody eats meals which are heavy, means a lot of fat, that increases the acid production. And also somebody is going through stress, emotions, that can also increase the level of hydrochloric acid. Okay, any questions so far? Any question, guys?
Can you repeat the first thing you said about HCl?
About HCl?
Yeah.
Okay, so are you talking about the pepsin? Pepsin?
Right before you said the breakdown of food, mechanical and chemical.
Yeah, that's pepsin.
Okay.
HCl help converting pepsinogen into pepsin, which is helpful in digesting proteins. Okay, I'm going to show you a real quick video, okay?
When you realize bloating and discomfort don't have to be routine, everything changes. Try.
Hi, I'm Dr. Vincent Ho. I'm a gastroenterologist and a senior university lecturer. I'm also the gut doctor. Have you ever wondered why you get heartburn or why you feel a bit of food coming back up into the mouth shortly after you eat? Today, we have a great animation covering acid reflux. Hope you enjoy. The story of reflux disease is an interesting one. We know that gastroesophageal reflux disease is a chronic, relapsing condition in which the reflux of stomach content into the esophagus and beyond can provoke symptoms and complications. There are multiple mechanisms that contribute to the development of gastroesophageal reflux disease. In order to better understand these mechanisms, let's first talk about what happens with digestion. The esophagus is a long, muscular tube that carries food from the mouth to the stomach. The worm-like contractions called peristalsis push food down the esophagus. At the bottom of the esophagus, food passes through a muscular valve called the lower esophageal sphincter and then passes into the stomach. The digestive juices secreted by the stomach are highly acidic, and when the stomach contracts to move food into the small intestine, the lower esophageal sphincter shuts tightly in order to prevent these acidic juices from moving back into the esophagus, where it can lead to damage. A large muscle responsible for helping us breathe, called the diaphragm, separates the chest from the abdomen. To reach the stomach, the esophagus passes through the diaphragm at a point called the diaphragmatic hiatus. If the resting tone of the lower esophageal sphincter is lowered because of diseases such as sclerodoma, where there is fibrosis of the lower esophageal sphincter, then the valve can't close properly, and that means stomach acidic contents can very easily reflux back into the esophagus. If esophageal peristalsis is weak, then this means that the ability of the esophagus to clear acid is impaired. And this means acid hangs around longer in the esophagus and therefore is more likely to result in damage to the esophageal lining. The most common mechanism for reflux for most people is transient relaxation of the lower esophageal sphincter. This allows for gastric contents to flow back up the esophagus. Anatomical factors such as a hiatus hernia play a role in contributing to reflux. If you have a hiatus hernia, a portion of your stomach is protruding into your chest cavity through the opening in your diaphragm. A hiatus hernia can increase the risk and severity of gastroesophageal reflux disease. Some patients with reflux symptoms may experience hypersensitivity to pain in the absence of excessive esophageal acid exposure. This is called visceral hypersensitivity. The exact mechanism for this is unclear, but it's thought that there is altered processing by the brain of nerve signals coming from the esophagus. Finally, we know that the ability of the esophageal lining or mucosa to withstand injury is really important in the development of gastroesophageal reflux disease. The cells that line the esophagus try to keep acid out by having tight junctions between cells and also having a way to neutralize any acid that diffuses back into the mucosa. One of the first things that can happen if reflux acid overwhelms the defenses of the mucous lining is that it can damage the junctions between cells, and acid can get into those spaces between cells, leading to further damage. The acid exposure can damage the esophageal wall and cause erosions. The esophagus may scar and narrow, resulting in strictures. In some patients with chronic reflux, the cells that line the esophageal wall are transformed, resulting in a precancerous condition called Barrett's esophagus. I hope you've enjoyed the animation. Make sure you subscribe to this YouTube channel if you want to learn more about the gut, and check out our social media links down below.
Okay, hope the video kind of explained visual learners that what this condition, what the problem is. Any question? Everybody understand the concept? What's happening with the patient? Right, if no question, let's move on. Now, let's talk about the solution, guys, okay? Let's talk about solution. Solutions are the acid controlling drugs based on the condition as well as severity and how quickly the solution is required, okay? And is it something occasional? Is it something regular? So that helps in determining that which option would be appropriate for your patient. Now, one of the starting points, I would say, those are your antacids. If you have too much acid, you pick up a base and neutralize it. These are your OTC products, such as your aluminum, calcium, magnesium. That's what the active ingredients in that. And then you take it, base go, bind with acid, neutralize, throw it out. So know their mechanism of actions, how they work. That is extremely important for all of them. Okay? So antacids, how do they work? They neutralize the stomach acid because they are base. Somebody asks you, what's in there? An antacid. These are aluminum, calcium, magnesium salts. Okay, we'll talk in detail. Then step up is your histamine receptor antagonist, or they call H2 antagonist or histamine receptor blockers. Okay, now here it is important to understand that we do not mix it with other histamine receptor blockers, such as Benadryl, right? They're also histamine blockers. What is the difference between them? Anybody knows?
It's for allergies, and then H2 is for, right? And H2 is for your stomach.
Okay, now if you look at it, it says H2 antagonist, right? That tells you that they block the histamine 2 receptors. Histamine 2. Your Benadryl, which is used for allergies, that blocks histamine 1 receptor. So that's for allergies. These are two different receptors. So please know which one belongs to what. Your Benadryl belongs to H1, which is associated with allergies. Histamine 2, that belongs to histamine receptor 2 related to acidity. Everybody clear? Okay. And as the name says, H2 receptor antagonist. So they block the histamine 2 receptors from stimulating acid production in the parietal cells. So it reduces the acid output. Okay. Now, do antacid reduce the production? No, they just neutralize. But these histamine 2 receptor antagonists, they don't neutralize, but they reduce the production. Now comes to the most important, the PPIs. They are proton pump inhibitors. As the name says, they inhibit proton pump in the parietal cells. And what they do? Highly active in what? Blocking release of acid. They pretty much completely, I would say from 95 to 97% of your acid production is blocked by PPIs, like your omeprazole, pantoprazole, lansoprazole. Those are your PPIs.
So, Professor, are PPIs like the most effective long term?
They're most effective and has, yes, long-term effect. They don't act quickly though. They take longer than antacid. Like somebody's experiencing acidity now, it seems they need help now. That would be antacid, not PPI.
Like Tums?
I'm sorry, what was that, Munir?
I said like Tums. The quick.
Correct.
Yeah.
Okay, now another ones are your prostaglandin analogs such as misoprostol, which increase the production of mucus, and bicarbonate, which is a base. So inhibit acid production as well as kind of provides a protective layering. Okay. There's another video I'm going to show it for a brief period. I'm not play the whole. It could be a little lengthy, but you can watch that video later if you need more explanation. But let me play it for a little bit.
Think of a poem about your identity. Funding our school is a big challenge.
Hey guys, Nurse Mike here, and welcome to simplenursing.com. Check out our brand new
Actually,
app
it's not
to
a
get
long one, it's a
access
short
to our
one.
new pharmacology and med-surg mastery courses. Join for free. Click the link and begin. Now for the drugs that reduce acid and prevent ulcers. The number one goal here is to protect the GI from its own acid. So number one, to tone down acid volume, we use antacids, H2 blockers, and PPIs. And number two, to protect the lining from those holes or peptic ulcers, we use mucosal protectants. The name for this is sucralfate. Now, a quick recap on the key terms here. Guys, gastritis is an irritation of the stomach. GERD is gastroesophageal reflux. Just fancy words for heartburn, acid reflux that irritates the esophagus. And ulcers are all about breaking in the lining, talking holes and open sores. So a stomach ulcer, we call it gastric ulcer or a peptic ulcer. And for small intestines, we call it a duodenal ulcer or a duodenal ulcer. Basically, the duodenum inside the small intestine. Now, antacids are used for fast, immediate relief. So think anti-mixing for antacids. They're never to be taken with other meds. Probably the biggest test topic I can cover right here. Now, it works by immediately neutralizing stomach acid. But the bad news here is that it doesn't last long. So the acronym we use is SCAM. Like you kind of got scammed from the short duration of the med. So S for sodium bicarbonate, brand name is Alka-Seltzer. C is for calcium carbonate, brand name Tums and Rolaids. A for aluminum hydroxide, and M for magnesium hydroxide. Brand name is Milka Magnesia. Now that's also a laxative as well as an antacid here. Now guys, the big side effects can vary on the type of antacid. Thanks for watching. For our full video.
Okay, I believe I may have another one. Let's see.
And new quiz.
Okay, now once again,
Professor,
overview.
he said never take it with any other drug, right?
Correct. Do not take it together. It's not that they cannot be taken, but they cannot be taken together. You have to space them. Okay, separate them.
Thank you.
Okay. Now, once again, guys, antacids, they act against the acid by neutralizing them. So please know the mechanism of action of all three, okay? Which ones are antacid? Like calcium, aluminum, magnesium salts. They act quickly, but they don't last long. Good thing is they act quickly. Bad thing is they don't last long. Everybody clear? Understood? So when you need a quick relief, short-term relief, that's when you use them. They're not going to manage your chronic symptoms. Number two, H2 receptor antagonist or histamine receptor blockers. They block the histamine from stimulating acid production from where? In the parietal cells, which reduce acid output. Examples. You will see tadine at the end, ranitidine, famotidine. Those are your histamine receptor blockers, like your Pepcid, right? Everybody knows what that is? That is famotidine. Okay, now, they don't act that quickly. If we compare it with antacid, they're still faster than proton pump inhibitor. They take longer though, but they produce its action as well for a little longer as compared for antacid. Okay, at least for a few hours. Here comes the PPIs, the proton pump inhibitor. So proton pump inhibitor, they block the proton pump. Where? Parietal cells. And this is the one which significantly reduces or pretty much completely block the release of acid. Example, they end in prazole or meprazole or abeprazole, all those lansoprazole, these are all your PPIs. They do not act quickly, but they last longer, at least 2-3 days, or could be more, okay? But this is the difference between all three. Any question about any of them?
So the mechanism of action between H2 and PP's eyes are the same. It's just the duration is different.
Okay. Duration and the extent of acid blockage. H2 receptors, they reduce it, but they do not block it as in the case of PPIs. They're much more effective in blocking almost close to complete production for those 2-3 days.
Okay.
Does the PPI also work with the H2 receptors, or is that different? Like, do they work with the cells instead?
Okay, so remember, H2 are associated with histamine receptor. Your proton pump is associated with proton pump in the parietal cells. Which is also called hydrogen potassium ATAs, proton pump. That's another name. Okay, everybody's okay? All right, no question, let's move on. We are gonna go over the same kind of information again, guys, okay? Same kind. Antacid, once again, mechanism of action. What they do, guys? Come on, quick. How do they work?
Neutral.
What was that, Harjot? It was too quick. I didn't hear.
Neutralize
Neutralize gastric acid, right? So what are the examples?
the sodium bicarbonate, calcium bicarbonate, aluminum something, and magnesium.
Yes, good job. Okay, so we know what they are, which one are, and then how they work, right? Everybody clear? All righty. Now, for example, your calcium carbonate like Tums, but these, all of them, they come with some adverse effects as well and some cautions we need to take. Okay. Now this is important and make sure you know it. Okay, write that down. As we talked about, aluminum, calcium, magnesium. Okay, 3 things. What do we turn on in hot weather to chill?
The AC.
AC, right? AC. Everybody turns that on heater, right? AC. Write down AC. What that means? Aluminum and calcium. That will stay together. Okay? What that means? Any antacid product which has aluminum or calcium, the patient may experience another C, means constipation. So you educate the patient, more fluid and fiber. Understood? AC stay together, both cause constipation. All right, and we talked about the solution, more fluid and fiber. Now, what was the third one?
Magnesium.
Magnesium. Now, magnesium don't like AC. They said, I'm too cold. I'm going to go in the hot weather. So turns around, his face on the other side. And what is opposite to constipation?
Diarrhea.
Diarrhea. So any product which has magnesium in it, that antacid, it may cause diarrhea. Everybody 100% clear about that. Which causes constipation, which causes diarrhea. Yes. Now you may see products which have either alumina or calcium or magnesium individually. You may find they are in combination. Sometimes if there's aluminum calcium, they intentionally add magnesium, which can counteract the constipating effect of aluminum calcium. Okay, same way if they're making magnesium, they could add aluminum calcium, and it will also have additive effect for multiple ingredients. And along with that, some of the products you may find an anti-gas, or also called antiflagellant, which is simethicone, added into some of the products as well. Or you will see simethicone as an individual product, for example, a Mylicon baby drops. You know, those intake gas for the babies, simethicone. What they do is the babies, when they drink milk, so they also ingest a lot of air and it develops air bubbles. And that's when they're gassy, they're colicky in the first few months of their life. And then when you give them simethicone, so simethicone, it acts like a surfactant, like your detergent, right? So it reduces the surface tension of that bubble around the gas, helps breaking down the bubble, and the burp or the pass gas the other out. Okay. Now examples like your magnesium, which has magnesium hydroxide, that is your milk of magnesia. Then your aluminum, that's like example Amphozel. Calcium carbonate are your Tums. Sodium bicarbonate, these are your Alka-Seltzer has that. Okay. Now, once again, we all clear how they work. Neutralize the gastric acid. They do not do anything to block the production or anything. Right? We're clear? So don't mix them up. Now they act quickly, but they don't last longer. Okay? So what are the indications for acute relief when somebody needs a quick relief? Because we know it acts quickly, even though they don't last longer, but they help well in acute relief. That's why I use these Alka-Seltzer and stuff for acute relief. Right? Okay, now contraindications. Let me give you some examples. Alka-Seltzer. What does it have, Alka-Seltzer?
Sodium.
Sodium bicarbonate. Patients with what condition should not be consuming too much of sodium?
Hypertension.
Heart failure.
Yeah, hypertension, heart failure, chronic kidney disease. They should not. So that's a contraindication, right? Everybody agrees? So patients sometimes they don't know, oh, I'm taking medication. Well, do you see what's in there? It may not be safe for them. If it's a calcium containing product and the patient has too much calcium, in the body, it's a hypercalcemia. That is a problem. And then if the antacid has aluminum, then it can reduce the phosphate level in patients, can cause hypophosphatemia. But mechanism of action and contraindications, these are extremely important about your antacids. And as I said earlier, do not give antacids with any medication. Now, once again, here is one part of your AC, aluminum, calcium, aluminum here. Aluminum and calcium causes constipation. Make sure you know that. Okay, now another important factor. This is recommended for patients with renal disease. Remember the previous one, we cannot, correct? The sodium we talked about, renal condition shouldn't. So this is the solution. Aluminum can be easily flushed out via kidneys, through kidney. So this is a good option to give. Okay. And mechanism of action, same. Neutralize gastric acid, okay? Here comes the magnesium, the third one. It can cause diarrhea. Diarrhea, like your milk of magnesia, which has magnesium hydroxide as an active ingredient. Once again, how does it work? Neutralize stomach acid, which is HCl, hydrochloric acid. So diarrhea is important too? No. The second important thing, or actually third one important, is do not give in patients with renal failure. Kidney failure patients should not take it. So what was our option for kidney patients?
Aluminum salts.
Aluminum. So aluminum can be taken, others can't. Okay, here comes your calcium. Calcium, once again, antacid, which has calcium carbonate. Example, Tums right there in the picture. Neutralized gastric acid, HCl. Used for heartburn, indigestion, and all that. Work quickly, doesn't last long. Now, your bad thing about it, adverse effect, right? The problem with here is it is a part of air conditioner, AC, aluminum, calcium, and this is calcium, cause constipation. So remember that. If somebody's calcium is too high, shouldn't take that. Or somebody has kidney stones, shouldn't take that either. Okay, here's your Alka-Seltzer. Sodium bicarbonate. It has sodium bicarbonate, citric acid, and aspirin in that. So somebody who's at bleeding risk, that could be a problem as well. Somebody hypertension, this is the problem, sodium bicarbonate. Once again, how does it work? Neutralize the stomach acid, HCl, hydrochloric acid. Used for same, heartburn, indigestion, all that. And here comes the contraindication. Contraindication in hypertension, heart failure, CKD, chronic kidney disease. It's a no, 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 and no. Okay, any questions so far?
I wanted a quick clarification on calcium. Calcium causes constipation and it can cause kidney stones.
It can, but I'm concerned about the patient who are already at risk. Either they have or they have a history of developing kidney stone. Hope that makes sense.
Okay, thank you.
Anyone else, guys? Any other question? All good? So have the permission to move on, guys? Yes?
Yes.
All right. Thank you for your generosity, guys. All right. Here comes anti-flatulent or anti-gas. And the one you need to know, that is simethicone. So they used to relieve like discomfort, bloating, excessive gas in the GI tract, and then help in expulsion of the gas. As I said, how does it work? The mechanism of action, it helps in breaking the gas bubble. Reduces the surface tension. And the brand names are like Gas X. There's a Mylicon, which is also called, the baby gas drops. So Mylicon baby drops, very commonly used, I would say, from up to first 6 months, or it could be 8, 9 months. Some like my son, when he was a baby, like he was a colicky baby. I don't know how many different type of bottles I had to switch because all bottles are not same. Feeding bottles, they're different. There are some which are really good and not allow air to ingest, but majority of them, they don't do anything. It's just the babies are like so colicky and then cry all the time. You're helping them burp, but they're not able to because there are a lot of those gassy bubbles and there, and then stomach pain and all that. And babies can't explain. They can't tell. All they can do is cry. So simethicone usually given after every feed, and then that helps breaking down those bubbles. Okay. Adverse effects. These are same which we talked in the drugs, but they're just listed here again. Now, one thing we need to remember here, guys. The problem is acid, too much acid, correct? That's the problem, right? Now you are using the drug to fix it. What can happen if you just fixed it a little too much? What is opposite to acidosis?
Alkalosis.
Alkalosis. And is it metabolic or is it respiratory?
Metabolic.
Metabolic. Respiratory associated with
Metabolic.
O2, CO2. Metabolic. Yes, good job. So your patient could be a risk of metabolic alkalosis, means too much base in the body or too less acid in their stomach. That's what can happen due to overuse of these medication. So that's what you should be watching for. Okay. Now, same information. AC, aluminum, calcium causes constipation, and magnesium goes the other route, causing diarrhea. And for calcium can put you at risk for kidney stones. That's what is important. Okay. Interactions. As I mentioned in the beginning itself, the biggest thing to avoid any interaction is do not give with any other medication. The biggest reason, they will reduce the absorption of any other drug taken along with them. Okay. Now, usually, these drugs, I mean, antacids are a little different, but your PPIs and all that, you try to take the best time is to take it in the morning. And your patient may have hypothyroidism. They might be taking levothyroxine. Their iron might be low. They might be taking iron. But if they're taken together, it will reduce the absorption of levothyroxine, iron, and the patient may experience more symptoms. Okay. And they can also cause a bit of electrolyte imbalance as well. So the recommendation is that any medication, it should be at least from 1 to 2 hours separated. Okay. I'm not worried about that. Don't worry about this part. Okay. We talked about this. What we have to watch for: renal disease and heart failure, pregnancy, and let me see. Now, this is also the same thing what we just talked about, guys, because it's important. That's why I try to put it multiple times that you don't forget and gets refreshed again and again. Any medication your patient has to take separate by minimum 1 to 2 hours. That's a big thing. They test all the time on these. And then also those aluminum, calcium, magnesium, whatever the adverse effects are. Now, if it's a chewable, make sure they chew it before they swallow. And if it's in powder form, make sure they mix it in enough water, as in case of your Alka-Seltzer. Okay. Now, another important aspect to remember, you have to think out of the box, guys. Okay. Think out of the box. As a super nurse, have clear vision without boundaries. What I mean by that, patient with clear symptoms of acidity, okay, but they're coming back over and over with those symptoms, getting worse. Don't just take it as, oh, the patient is experiencing just more frequent heartburn. Think out of the box. What that means is there's several type of even tumors, cancerous tumors, which can cause excessive release of acid. Now, what is the purpose of these drugs? To suppress the acid, right? The patient's symptoms will be suppressed. But what if it delays the diagnosis of a cancerous tumor? You're just suppressing it rather than trying to see that what else it could be. So think from those perspectives as well, that there are other reasons which can cause excessive release of acids. They should be seen for further evaluation. This is repetition. Aluminum, calcium causes constipation, magnesium causing diarrhea. Now, let's move to the second category, histamine 2 receptor blockers or antagonists, okay? Now, they do not neutralize acid, so their mechanism of action is they reduce secretion of acid. How? By blocking the histamine receptor. Which one? Number 2. Where? On parietal cells. We use for the same conditions, GERD, peptic ulcer disease, gastritis, Zollinger-Ellison syndrome, and all that. You identify them, they have tadine at the end. Ranitidine, famotidine, all those, they are your H2 receptor antagonist. Okay. This is same, guys. This is, we just talked about, nothing new. Adverse effect. Okay. Not too many, but one thing important to know is we have to be careful if you're giving it to too old patients, older patient population. Why? It can cause CNS adverse effects. It can cause more confusion and disorientation in these patients, and it makes puts them at a high risk because your older patient population may naturally at that point of life might be more confused and disoriented. Plus, they might be on certain drugs, which can increase this risk of confusion or disorientation. So that is very important about these drugs. Okay, any question? You should monitor their mental status changes when they're taking this medication. All right. Drug interactions. Now, this is also important. Smoking is a no-no with these drugs. The reason? If somebody smokes, they take H2 receptor blocker, it's probably not going to work because smoking can decrease the absorption of these drugs. So very important about that. And it can happen very commonly. It's people smoke all the time and then feel, acidity, and they're like, oh yeah, I can take this, but it's not going to help much. Okay. Now, nursing implications, these are very basic things, guys, that look for any underlying condition, medications they're taking, which can put them at a high risk. And if the patients are old, they're already confused, disoriented, well, that's a no. And even though they are not, if they are on these medication, make sure you're monitoring any signs and symptoms associated with that. Okay? And here comes the third one, PPIs, proton pump inhibitor. Now, one more time, their mechanism of action, they block the proton pump. Where? In the stomach, parietal cells, and those are responsible for acid production. When you block them, they're not able to produce more acid. And they end in prazole, omeprazole, pantoprazole, esomeprazole, lansoprazole. These are all your PPIs. Now, there's some side effects. If your patients are taking it for long term, they might be deficient in vitamin B12. Okay, that is important. And another important thing about them is long-term use, especially older population, they might be at a high risk of fractures. makes their bones weaker. This was not the case a few years ago. Everybody was, oh, they are completely safe. They're completely safe. And all of a sudden, the reports came over of long-term studies, and the data clearly show that with long-term use, it makes the bones weaker. So if they're going to take it for long-term, well, you got to look into multiple things. You may have to educate them, encourage them to take more calcium, vitamin D, as well as probiotics. Why? Because it decreases the production or blocks the production of acid. And when acid is low, well, your patient at high risk of infection, especially in the gut. Okay, this is just a visual aid in here that the proton pumps, which produces acid, they are blocked by these drugs. And then there's very lesser now production of acid. And these are some examples which we talked about. This is how the bottles looks like. Now, important, these should be taken empty stomach in the morning. Okay? Do not crush, chew, or anything. If they're capsule, should be swallowed completely. And they are the ones can be used for long term to maintain healing. Okay. Now, any of these drugs you're giving, what is the therapeutic outcome you're hoping for?
Relief, less acid reflux.
Yeah, that they're saying that I don't have I don't feel heartburn anymore, right? Or maybe at least reduced. I know it seems very basic question, but remember, they can ask you anything. It's important. Okay, we talk. Okay, now this is also important that if your patients are taking it for long term, what can happen is it can cause achlorhydria. What that means is no acid in the stomach. And as I said, acid is also body's defense mechanism, right? And then when there's no acid, then the bad guys in the gut can raise their hand and say, hello, I'm here, right? They can make your patient sick. The condition is achlorhydria. Who do we give it to? Same conditions, guys. GERD, gastroesophageal reflux disease, and all that. Nothing different. Adverse effect. As I said earlier, number one is weak bones. Weak bones. We know the problem. The solution is educating the patient to take calcium and vitamin D. Okay. Number two, your patient might be risk of infections. Next, your patient might be deficient in some nutrients, very commonly vitamin B12. It could be calcium, magnesium, but vitamin B12 very common that they might be deficient in if they're taking it for long term. And long-term use can put your patient at risk of another infection, C. diff, Clostridium difficile, C. diff infection. That is also very important to know about that long-term use. Your patient might be at risk of that infection. Okay, any questions so far, guys?
I had a
Anyone?
question. Did you said something about vitamin D?
Calcium,
You said
vitamin
it.
D, that's an
Yeah.
older population, or somebody has
Yeah.
like osteoporosis, osteopenia, then patient will be at risk of fractures. So to those patients, you should recommend taking calcium, vitamin D.
Okay. So PPIs deficient in B12 and vitamin D, and then that's what you said to increase probiotics because of what again? Is it because
Infection.
of the okay, okay.
Probiotics are your good gut bacteria, right?
Mm-hmm. Gut health.
So they just, because when you take it for too long, then there's an imbalance in the gut environment, good and bad bacteria. So then you may need those probiotics. And it's common if you go to old age homes and, where there's more older patients, if they are on antibiotics, you will see this very commonly given along so that they can keep a balance. Because when you give bacteria, yeah, sorry, not bacteria. Oh my goodness, antibiotic. Then antibacterial. Oh my goodness, I'm flipping, guys. Okay, antibiotics can kill good and bad guys. Okay, so bad guys are bacteria, good guys are the good bacteria in the gut which you need, and that will go down. And when they go down, now your defense is weaker, and that's why you give it from outside to keep that balance.
Okay.
Okay. This is nothing to worry about. Okay. Now, a few other things here. When taken together, it can alter the level of other drugs. For example, some antifungal, like who ends in azole, like ketoconazole, itraconazole. So these PPIs, they reduce acid. Reduced acid means a more basic stomach pH goes up. And that increased pH causes reduced absorption of these drugs. So they won't be that effective. Similarly, iron, if somebody's taking iron, absorption will go down. That's why we separate them. Same with some blood thinners like Plavix, clopidogrel, um, decreased absorption, and patient might be risk of clotting. Um, on the other hand, if they're on warfarin, it actually can increase the risk of bleeding. Okay. Now here, you don't have to memorize everything, but I just like to put it in so that you know what these are. Um, these are your enzymes, CYP enzymes. They are crucial in metabolism, all these drugs. And having less or more can impact the efficacy of the drug. Okay, and your PPIs can interact with them, and that will eventually affect the metabolism of many, many drugs. Now, for example, these CYP, there's CYP2C19, CYP3A4, CYP2D6 is usually for your pain medication opioids. So these are different enzymes, CYP enzyme. So CYP2C19 is the primary one, which is affected by the PPIs, like your omeprazole, esomeprazole. What happens is, for example, somebody's taking clopidogrel, Plavix, right? And taking PPI, omeprazole. Now that will inhibit the enzyme CYP2C19. And when the enzyme is reduced, what's going to happen? It's going to reduce the conversion of clopidogrel into its active form. And when that is reduced, less active form means the reduced efficacy of the drug. Now, what is the use? It's a blood thinner. When the efficacy of a blood thinner is not sufficient, the patient is risk of what? Clotting, right? So that's how it can affect. Okay. Now, there are drugs which are either inhibitors or inducers of these enzymes. And as I just said previously, that how they can impact. So if something can induce the enzyme more, the metabolism will increase and can put the patient at risk of toxicity. But if it reduces the enzyme, then there's less efficacy. It can go on both ends. And here's some examples of some drugs, what they can do. Like, for example, here, these barbiturates, St. John's wort, carbamazepine, rifampin, and all those. So they are inducers of enzyme. Okay, and the inhibitors right here. So when they reduce the enzyme, basically metabolism will be low, less efficacy here, more enzyme, but can put patient at risk of toxicity. And that's what happens in case here. If somebody's taking diazepam or phenytoin or warfarin, these drugs can increase the enzyme and can put your patient at risk of toxicity. Okay, now if somebody cannot swallow, they are on, for example, they said they are on tube feeding and they have NG tube. Now on the larger gauge, it can be given by opening and just kind of pushing it through, or they can be mixed on like applesauce and something and kind of swallow, but they shouldn't be chewed. Now here are other drugs. Simethicone we talked about, like Mylicon baby drops. Let's talk about these two, sucralfate and misoprostol. Excuse me. Sucralfate. First of all, it is a cytoprotective drug, a protective drug. For that, we need to know its mechanism of action. What does that mean? As it say, protective drug. What it does, it protect what? Wherever the problem is. The problem, too much acid, doing what? Damaging the stomach lining. So it protects the stomach lining. How? It coats it. A protective layer over the stomach. Usually patients with stomach ulcers. Think about it. What are ulcers? What are ulcers?
Like cuts
Cuts,
or
right?
openings. Yeah.
So think about the stomach ulcer, like cuts in the inner lining in the stomach, which can bleed as well, right? There's a cut, can bleed, right? So when patients who has stomach ulcers, when they eat food, when you eat food, what happens? Body release acid, and that acid is going to damage that ulcer, that wound, even more. Correct? Somebody's taking NSAIDs and all that, that's gonna damage the lining even more, making that ulcer worse, put them at a higher risk of bleeding, correct? Now, when you get a cut on your skin, what do you put on the skin?
A Band-Aid?
A Band-Aid, right? Band-Aid is what? What does it do? It protects from getting in contact with anything, right? Same here. Sucralfate protects that cut, the wound inside, right? And then does not let the acid to come in contact with that cut ulcer to damage it further. Does that make sense? So that is the purpose. That's how it works. That is important, okay? It's mechanism of action. It forms a protective barrier. So it promotes healing of those ulcers. It doesn't reduce acid or anything. Okay, everybody clear? How does it work? Now, important again. We know that it's going to form a protective barrier, correct? Protective lining. Now, think about it on your skin, okay? On your skin. You just put something to cover it. For example, say just, just say that you picked up a polythene bag, right? The polythene bag, put it on. Now you're trying to apply the cream on it. Now, is the cream gonna reach your skin? Is it gonna make it look like fresh and all kind of hydrated or anything? It won't, right? Because it's not even reaching the skin. There's a barrier, correct? So same here. When somebody took this medication, the inner lining, around the inner lining, it coats it. And when it's coated, now that inner surface area, the stomach line, which is important in absorbing either its nutrients, either it's a drug, it's not available because the drug is or nutrient, they're not going to reach the lining or that surface area. It's coated now, right? So what can we do? Well, any other drug separated at least 2 hours if your patient is taking sucralfate, because otherwise the absorption of other drugs will be very, very low. That is important to know about sucralfate. Okay. Now here, misoprostol. It's a prostaglandin analog, prostaglandin E1 analog. Now, this drug, the mechanism of action, how it works is that it increases the secretion of mucus as well as the bicarbonate. So mucus also protects the inner lining, okay, wherever the ulcers are. So it protects them. And also increase the production of bicarbonate, which is a base and can neutralize acid. Okay. So it's not an antacid or anything. It just promotes the natural protective mechanism of the body itself. So that's not the primary purpose or mechanism of action. That it did to some extent, yes, but not the primary reason for the gastric acid reduction with this. It's very commonly used with NSAID-induced ulcers. Okay. Now, one of the most important thing to know about this drug, it's contraindicated. Okay, contraindicated in pregnancy. It can cause abortion. So that's very, very important about this drug. Everybody clear? Any question? Okay. And these are your Mylicon, Simethicon, those baby drops, okay? Gas relief drops. The one on the top. And these also has Simethicon, but these are more for adults. Okay, it's called anti-gas or anti-flatulent. Now, mechanism of action, once again, important, okay? It breaks down the gas bubbles. How? By reducing the surface tension of gas bubbles and break them. Help an expulsion of the gas. It's not absorbed in the bloodstream. It's just a no systemic absorption. Okay. All right. Let's do a few questions and then we'll take a break, okay? Okay. What do you say about that? How does sucralfate works? Guys, remember? Can anybody provide patient education here?
It coats the stomach lining, similarly to how when we get a cut on our finger, we put a Band-Aid on it.
Absolutely.
And when
Yeah.
taking other medications, it should be taken at least 2 hours before sucralfate.
Yes. Good job. Good job. Good job. Perfecto. Alrighty. Okay, how about that? Excuse me.
Would it be neutralizes gastric acid?
Yes. Yes, and yes. So your antacids, they neutralize the gastric acid. So C is the correct choice. All right. How about this? If you guys want, you can type your answer in the chat. That'll give everybody opportunity to read the question and answer. Good job, guys. Okay, C is the correct choice because they are antacid to reduce the acid, but while you're doing it, to fix too much, the other condition, completely opposite, metabolic alkalosis. That's what can develop. Okay, next. Come on, guys, everyone. I want everyone to read and answer. Remember, guys, these are the tools to do well in the course, in your exams. I don't want you to just listen. I want you to engage in the learning. Okay, C is the correct choice, guys, because it is contraindicated in pregnancy. Okay, let's see if you remember, guys. Excuse me. Okay, excellent. Perfect. So B is the right choice. Remember AC, aluminum calcium causes constipation, magnesium causes diarrhea. And I'm just telling you here again and again, remember this AC stays together causing constipation, and the third guy causes diarrhea because they get mixed up real quick. Which one causes what? When you get a question, I want you to be 100% clear. Okay, good job. Yes, B is the correct choice. Magnesium. Magnesium is the one which should be questioning because the patient who has chronic renal failure, they're not going to be able to expel the magnesium, and the condition develops is called hypermagnesemia. Okay. Now, this was not covered, so let me go over. Famotidine, which is your histamine 2 receptor antagonist, can put your patient at risk of thrombocytopenia, which is the decreased number of platelets, which can put your patient at risk of bleeding. Okay. How about this?
Sorry, what was the last one? The one before this one?
It was D.
D. Okay.
Okay, good. So B is the correct choice here. They compete with the histamine receptors. Which one?
H2.
Yes, H2. H2. Okay. Okay, good job. D is the correct choice, as we talked about. Your H2 receptor blockers, their efficacy could be decreased by smoking. And these patients, who experience these acid issues, they should avoid spicy foods, even extreme temperatures, alcohol, smoking. All these are not good. Okay. Cimetidine can be taken with or without food, but the PPIs, your especially, should be taken empty stomach. Okay. And another important part I would add here about your H2RAs, your histamine 2 receptor antagonist, such as your cimetidine and stuff, the patient can divide the meals into like smaller meal portion, like 5, 6 during the day. They should avoid eating heavy meals because the heavier meal they're going to eat, more the acid body is going to produce to break it down. So they should split their meals into smaller meals, and that will not only reduce the acid, also it will increase the effect of these histamine 2 receptor blockers. Okay. Next. Come on, guys. Okay. So, majority answering A. There's some D's as well, guys. Remember, this is what is gonna mix up. You gotta make sure you understand what is what. So, PPI proton pump inhibitors, they block the proton pumps in parietal cells who release acid. Okay. and they irreversibly bind to the hydrogen potassium ATS pump. That is what called proton pump. When you're looking at D, look what they do. They compete with histamine. Those are your histamine receptor blockers, not PPIs. These are two different classes. Focus, 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 guys. The name itself pointing to the answer. Pump, 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 pump. Okay, nice. Good job. Yes, D is the correct choice. Achlorhydria. No acid in the stomach. Okay. Okay, it looks like majority of you are answering D. Can you please share what your thoughts are? Why, uh, to avoid? So the question is to teach a patient who's prescribed simethicone to avoid what substance, like why they should not be taking histamine receptor antagonist. It means that if simethicone for a patient, a kid, or anybody, for gas they are taking it, they should not be taking ranitidine, famotidine.
But it's an anti-flatulent, so it would be carbonated beverages, right?
Sorry, what was that, Bella?
Since it's a anti-flatulent, it's not an antacid, it would be carbonated beverages.
Yes, it's a carbonated beverages. A is the correct choice. You can give simethicone with histamine receptor antagonist. Yeah, absolutely. Okay, all right. We're done with the chapter. Any question about anything from this chapter? Anyone? Any question, guys? Please feel free to ask. No? Everything is clear? Okay. Ready to take a break? Okay. So it's 10:35. Let's come back at 10:45, okay? Thank you. Okay, welcome back, everyone. Okay, let's turn on the camera, guys.
Hi, Professor. I just wanted to reiterate or get help on something.
Sorry, what was that?
I just needed help on something. On slide 13, just talking about antacids and the contraindications. And on the very next slide, you said aluminum acids are okay for renal disease. So is that just the exception?
I'm sorry, I didn't get what your question was. Can you say that again?
Yes. So the contraindications for antacids, you said are severe renal failure, correct?
Mm-hmm.
So aluminum salts are just the one exception because it says that it's okay to give that for renal disease.
Correct. So if somebody who has that condition, then if they are experiencing, acidity, then that is the drug of choice to give them that can be safely given, but the other options are not.
Okay.
Um, Jessica, can you hear me, Jessica?
Yes, I can hear you.
Okay, and as well as Christy, if you could, both of you just later today, just speak with me for just quick 5 minutes, okay? All right, and then Kristen, can you hear me?
Are you talking to me?
Kristen,
Kristen?
not Christy. Austin Peterson. Can somebody send a message? Harshut, can you send a message in the group to reach out to me, Kristen?
Yes,
Just
I'll send a message.
if you could tell her to send a message. And
Professor, it looks like she's trying to talk to you. Her camera's on and she's waving, but it doesn't sound like her mic is working.
Okay, now it is. Now I can see Kristen. So your mic is not working, Kristen? Maybe it's one of it's probably the settings. You probably have to look into your settings, either the privacy permissions, or it could be just look at that you chose the correct mic there for input. Okay, so let's move on, guys. All right, next chapter is your bowel disorder. Okay, bowel disorder. So in this chapter, we're talking about different conditions associated with bowel, and then medications. And along with those medications, what comes along with them is the adverse effects, interactions, and all kind of stuff. And we'll talk about important aspects when you're developing your nursing care plan. So there are different illnesses associated with your bowel disorders, such as it could be irritable bowel syndrome, patient experiencing like abdominal pain, bloating, diarrhea, constipation, all that. And then inflammatory bowel disease, such as your Crohn's disease or ulcerative colitis. Then celiac disease. Then the most common ones, like your constipation and diarrhea, and more severe diverticular disease or bowel obstruction. So we'll talk about the most common issues here. First of all, diarrhea. Now, diarrhea is, the frequent passage of loose or watery stools, usually more than 3-4 times a day. Okay. Responsible factors, it could be an infection, maybe a virus like norovirus or bacteria such as very common E. coli. It could be some parasites. Others, such as food intolerance, somebody's lactose intolerance, it can happen to them. Then due to medications, very common with antibiotics, or if they are going through chemo. Then digestive disorders, as we just said, like your irritable bowel syndrome, inflammatory bowel disease, celiac disease. And patients can also have traveler's diarrhea, like, they're, excuse me, traveling, they consumed water or food, which was not clean, and then they ingested something along with that. Now, treatment is important. See, when they are going and passing stool, which is watery, they're losing fluids. So replenish fluids, keep them hydrated. So oral rehydration is real important. Now, when the water goes out, it doesn't go alone. They might be deficient in electrolytes. So keep an eye on their electrolyte levels as well. Now, as far as treatment plan with the medication, you need antidiarrheals, such as loperamide, which is Imodium, okay, brand name Imodium. In certain conditions, you may need antibiotics. And it's also essential to educate your patient about appropriate diet, such as brat diet, right? Banana, rice, applesauce, toast, so that you go easy on their stomach. But if they're severely dehydrated, they notice blood in stool, high fever, make sure they go see the doctor. Okay, this is what we just covered. This is what we could. Okay. Now, what are the goals? Goals are to reduce the frequency of the stool, right? So that they're not losing too much fluids. And then whatever needed, you need to replenish along with the electrolytes. Now, the drugs used, okay? Drugs used, antidiarrheals, different classes there. So purpose here to reduce the frequency as well as the severity of the diarrhea. Now let's talk about like your loperamide, which is OTC Imodium. First of all, how does it work? The mechanism of action of Imodium is that it slows down the intestinal movement. When you slow down the movement in the intestine, you are allowing more time for water to get reabsorbed. And then losing less. And this is given in acute diarrhea as well as in chronic diarrhea can be used as well. We're going to go a little bit, we're going to add a few more things later on, but I'm just going to go real quick. There's another one, Pepto-Bismol. I'm sure everybody has seen that powder OTCLs, which has active ingredient bismuth subsalicylate. That's active ingredient in Pepto-Bismol. So this reduces the inflammation in the intestine. It also has a mild antimicrobial properties, usually people with traveler's diarrhea, indigestion, there can be used. It binds with the bacteria and flushes it out. Okay. People may experience like a little black tarry stools and black tongue, dark color of tongue in that. Okay. Then more stronger, your anti-motility drugs, which are your anticholinergic and opioids, such as Lomotil, which has diphenoxylate and atropine combination. They are quite similar to loperamide, and they slow the intestinal movement, but they're much more stronger than that. And then atropine associated along with that, it just kind of blocks certain effects of diphenoxylate so that people don't misuse the drug. Okay. Probiotics, these are something given to replace and maintaining a balance with your normal gut bacteria. So once again, antidiarrheal, what we're trying, if they're going too many times, we want to reduce the frequency and want to hold on to the water more inside. Here is one of the common ones, OTC, Pepto-Bismol. So active ingredient is bismuth subsalicylate. Now let's go over important stuff once again, one by one. How does it work? How does it work? So it coats the walls of GI tract, okay, and then bind to the bad guy, the bacteria. It goes, say hello, make a strong bond, and just expel it out from the body through stool. Just flushing it out. Next, if you read the active ingredient, I know it's not clear, but bismuth subsalicylate. So it is a salicylate. Class it falls under, it is a salicylate. There is one real important thing to educate. Anybody knows?
Constipation.
Constipation can happen, yeah, but I'm saying important, not common. Most important. No? Okay. Number one, if somebody is at a risk of bleeding, then salicylates can increase the risk of bleeding. Number two, very, very important. Children, if they're experiencing flu-like symptoms, you should not give this medication because it can put your patient at risk of Reyes syndrome, R-E-Y-E, Reyes syndrome. Very important. That's a high risk. Everybody got that?
Is that just in kids or in everyone? The Reyes syndrome.
Not in everyone. It's more specific to kids. And you can say not only kids, you say adolescents as well. Okay. So adults, no, it doesn't apply to them. Children, it's very important. Okay. Here's your anti-motility, that it slows down the movement, and peristalsis, right? So that's an intestinal movement. And when that movement is slowed down, means the stool will take longer to pass through that tract before it goes out, before the patient passes the stool, which allows more time for intestine to absorb the water back from the stool, which makes the stool more harder, and also it extends the frequency. Everybody understood? How does it work? Peristalsis is the movement which is kind of pushing it up. And if that is fast, frequency is going to be more, as well as it's going to be watery because the water is not getting absorbed. When you slow it down, there's more time while it's moving to absorb water back. Okay? And these are your loperamide, your diphenoxylate, atropine, the brand name comes under Lomotil. So if somebody asks you how does it work, it's important to know. It's an anti-motility, means slows down the intentional movement, which is called peristalsis, and allowing more time for water and electrolytes to get absorbed. Okay, it's the same thing, guys, nothing important. But your these Imodium and these loperamide, it acts on the opioid receptors. Okay, so there's a little risk of developing that dependence on that. So, but again, it slows down the peristalsis. That's what important. Nothing else about that. We talked about that already. Now here's your probiotics. So probiotics, they work by replenishing the bacteria, the good bacteria that may have been destroyed by antibiotic therapy or probably flushed out because of diarrhea, and you kind of restoring the balance of normal flora and suppressing the growth of the diarrhea causing bacteria. It's making your army stronger. So they are live good bacteria or yeast that help maintaining, restoring a healthy balance of microorganism in the gut. And it's very commonly used in older patients, once again, to maintain the normal flora in the gut when they are taking antibiotics. This is a very common example, your Lactobacillus acidophilus. Then there are more like Bifidobacterium, Saccharomyces and stuff, but you'll see this Lactobacillus very common. Okay. Now for milder types of diarrhea, use absorbents like what we talked about, Pepto-Bismol and all that. For more severe, use anticholinergic opioids like your loperamide and stuff, or Lomotil, and probiotics are used. It can be used in any of them, but more kind of supporting your patient to maintain the normal flora when they're on antibiotics or diarrhea caused by antibiotics. Okay. Now, Pepto-Bismol, once again, bleeding risk, and because it's a salicylate, can also cause tinnitus, hearing issue, constipation, dark stools, and patient high risk of bleeding if they are especially taking blood thinners. And then as far as your anticholinergics, opioids, what can make them slow, sleepy, drowsy, dry? Sedation is one thing. Urinary retention can get worse. Blurry vision, blood pressure might drop, slow heart rate. Just remember the same thing. What happens with anticholinergic, your Benadryl or any opioid makes you slow, sleepy, drowsy, dry. So just remember that. Okay, it's the same thing, opioids, nothing different. Slow, sleepy, drowsy, dry. Okay. Now, interactions. These drugs can also decrease absorption of any other taken along with that. Just generalize it. That shouldn't be taken with any other drug. And as we talked about, certain drugs, as in the case of bismuth subsalicylate, can put your patient at increased risk of bleeding, especially when they are on any blood thinners. And once again, example of Pepto-Bismol. Bismuth subsalicylate is the active ingredient in Pepto-Bismol, should not be given in children, teenagers who are experiencing flu-like symptoms or chickenpox active, because it can put them at risk of Reye syndrome. Now, if the patient is experiencing a fever, and there, make sure you do not give them aspirin, you don't give them any salicylate, you should give them acetaminophen, Tylenol. That's what super nurse should do. But that is important as well. Okay. The patient has, maybe they have diarrhea, they have fever along with it, and you say, oh, you know what, let's give this Pepto-Bismol. No, give them Tylenol for fever. And once again, because some of your antidiarrheal can put your patient at risk of bleeding and all that. So you have to be careful, especially in older patient population. They may have a history of blood clots like myocardial infarction, stroke, or anything, and they might be on one of those drugs, and it could be risky for them. Okay, and just monitor patients' hydration level. Okay, that they're not dehydrated, and educate them to drink more fluids to keep them hydrated, replace them. If the symptoms become severe, especially if there's bloody diarrhea, then they should see the doctor right away. Okay, any questions so far? Anybody, any question? No? Okay. Now next, completely opposite, constipation. Okay, opposite of diarrhea, constipation. Now what is constipation? Well, in diarrhea, they were going too much, too many times. Here, they're not going enough, less than what they're supposed to. So it's infrequent and difficult bowel movements, and usually less than 3 times a week. Reasons, most common, diet. They're not drinking enough water. They're not consuming enough fiber. It could be because of medications they're taking, especially opioids. Right? Certain antidepressant can do that as well. Another common issue, no or less physical activity. Another factor could be some sort of medical condition they're experiencing, like irritable bowel syndrome, or patient has hypothyroidism. In hypothyroidism, they experience constipation. Or if they have some sort of obstruction in the colon, and they have difficulty passing stool, the stools are hard, they're more dry, and they can't go every day, it's infrequent, they're having discomfort, bloating in the abdomen. These are the symptoms experienced. And the first thing we should educate them about, increasing the intake of fluid and fiber. Fluid and fiber. If they include fiber but not enough fluid, they'll be more constipated. And then based on the severity, there are other products such as your laxatives, and they're different type, like your bulk forming, osmotic, stimulant, stool softener, and then Also encouraging your patients to engage in regular physical activity. Okay. Now, as I said, there are different type of laxatives. Before we go on discussing those, I want to point out one thing here. You may come across patients who are going for a diagnostic procedure. Okay, going for a diagnostic procedure, where they will be given something to drink, and there are studies where they gave barium, barium, barium. So what happens is after the drink, now you put the patient under the scanner, and now they can see the movement there, like wherever that liquid flows in there, it goes that they can see the whole tract. Okay, very clearly. Now, why I'm mentioning it here is you may see that those patients, they don't have constipation, but they're given a prescription for a laxative. The reason behind that laxative prescription is that they wanted to expel the barium out from the system. They want to get it excreted from the system. They don't want to leave it in the body. Could be toxic. So they use laxatives so they can go more, and it may kind of increase the frequency for a little bit so that the whole barium can be excreted from the body. But it's not something for constipation. It's just something completely different but unique. You may come across. I just wanted to share with you, but it's very important because sometimes here and there you will see those medications, but you will think like, oh, the patient doesn't have the condition. Why are they taking this? There's so many things which are, you know, different than the FDA approved indications there, the different things they're used for, condition that it can be used for. Now, when somebody eats the food, from here, the mouth breaks it down and kind of, salivary gland, they kind of secrete saliva through, pharynx, esophagus, kind of peristalsis, and goes down here. Stomach releases acid, breaks it down, and then liver, store the vitamins and all that, bile acids, which helps in digestion released. And then here, pancreas release insulin and help moving the glucose into the cells. And then your small intestine, this completes your digestion, protects the gut wall here, absorb nutrients, all that. And the large intestine, you absorb more water and then gets expelled through rectum as stool. Okay. So we need to understand the whole passage and then how does these medication help. Now let's go over them one by one. For example, we always, any condition, we start with the least, whatever the minimum required, and fluid and fiber is something starts with. So bulk forming laxatives are the only one which can be used for long-term use. Stimulant laxatives should never be used for long-term, can cause dependence of the bowel dependence. They can lose the normal bowel tone and they may not be able to go defecate without using that. Okay, so these are bulk forming, as the name say, bulk forming. They increase the bulk. Okay, how? It absorbs water into it, which makes stool more softer, and that soft is easy to pass. So somebody asks you, how does it work? Absorb water. It's an intestine, absorb water in the stool, makes it softer, easy to pass. Okay, examples. Like here on your screen. On the PowerPoint you see Metamucil, Citrusol, right, your psyllium, and then there's methyl cellulose, which is your citrusol, then Fibercon, which is a polycarbophil. So they are not quick. Their action is not quick. It may take somewhere from 10, 12 hours to even 2-3 days. And the patient may develop some bloating, gas as side effects while they're taking it. Very, very, very important, which I mentioned in the beginning as well. Make sure your patient understand that they drink enough water. If they don't, they may feel more constipated if they do not consume water with it. Okay, that's very important. Next are your emollients. Okay, these are like your mineral oil and stuff. Like your stool softener, one of the most common, docusate sodium. Colase, docusate sodium. Now, if somebody asks you how does it work? So it allows the water and fat to penetrate, mix with stool, soften it, and making it easier to pass. That is the mechanism of action.
Can you please repeat that, Professor?
Absolutely. So they do allow water and fat to penetrate and mix with the stool, and that water and fat makes it more softer, which is easier to pass. Docusate sodium, as I said, is the most common one. Stool softener. It's a stool softener, right? Now, a couple of important things regarding that. One is similar to what I said earlier. Make sure they drink enough water. They should drink enough water. Very important. Number two, it is important to educate your patient that it is not going to help them produce effect right away. It's not a stimulant laxative. Stimulant laxative works quickly. These don't. They're stool softener. And if the patient asks how long it will take, tell them it might take up to 3 days before you experience any beneficial effect from this medication. Because the patient might call you like, hey, I mean, the whole day passed. I mean, I was there yesterday morning and it's evening now the next day. I mean, the pill, whatever you gave, it doesn't work. You need to educate that it takes longer. Yeah, how many days? Around 3 days. Could be a little less or more, but somewhere around there. You should know that, please. And then emollients, they're also the stool softener, and they allow water and fat to penetrate that. And then others there are like mineral oil, like these. So they are more lubricants. They're more lubricant, allow easy defecation. So kind of preventing any kind of straining. If somebody has hemorrhoid, recent surgery, heart condition, when they should not stress when going to the bathroom, that's what can be used. Here's another commonly used, your Miralax, your polyethylene glycol. Lactulose, it's not that commonly used, but you see that these are called hyperosmotic. hyperosmotic, means increase the osmotic pressure. How? The mechanism of action. It's called via osmosis, process of osmosis. They increase the amount of water in the colon by pulling fluid into the intestine, which softens the stool and also stimulate the bowel movement. And these are the examples: polyethylene glycol, and then other like your glycerin suppositories. That's the same way they work. So it may take a day or two before they work. And lactulose, as far as lactulose, there's another use of lactulose. Patient who has high serum ammonia level, you may see this drug given as well because it helps expel the ammonia. Okay, next, saline laxative, like your milk of magnesia, then magnesium citrate. And this magnesium citrate you may see given along with polyethylene glycol. Patients, for example, going for like colonoscopy. So they want to see the whole tract clearly. So to make it clear, you will see polyethylene glycol as well as magnesium citrate given together like a night before they go for that procedure. It's they give like a big jar, like a 4 liter of polyethylene glycol and then magnesium citrate bottle. So they have to start taking it the night before, and it causes kind of diarrhea so that they can clean the tract, and they when they put the camera, they can see it clearly. Okay, that's another purpose. But as far as treating or helping a patient with constipation, so they are saline laxative, draw more water into intestine and soften the stool. Okay. Then here are the stimulant laxative. This should be the last resort, okay? And very, very, very important about them is the long-term use can cause bowel dependence. So educate your patient not to use for long term. They will experience a decreased bowel tone and bowel dependency, what we call. They will have difficulty passing the stool without this drug. So that's very important. And if somebody asks you, what is the mechanism of action? How does it work? So they act on the intestinal wall to increase the muscle contractions, peristalsis, and accelerate the movement of stool through the colon. So with these medication, your patient may experience abdominal cramps because they're causing more contractions. Examples: Dulcolax, most common, Bisacodel. Then there is Senna. These drugs act quickly, but they should not be used for long, not more than 3 to 5 days. Okay, everybody clear? Any question? This is not much to worry about. It's the same thing. Okay, so once again, your patients who are experiencing diarrhea, they're losing fluid and electrolytes. So please make sure replenish fluids and monitor electrolytes. Okay. And as I just mentioned on a previous slide, your stimulant laxative should not be used for long term. The reason may result in decreased bowel tone and lead to bowel dependency. Okay, I believe that's everything we just talked about. Okay, let's do some questions. Okay, let's see if you remember this. Come on, guys, come on, come on. What's happening, guys? I didn't get a response. Only one response yet. What's happening? And the concept mixed up? Take brief notes when I tell you it's important. Take brief notes. Don't try to write down too much that you're not able to focus. Just the brief notes. Okay. C is the correct answer, guys. It decreases the peristalsis. It's an opiate antidiarrheal. Decrease the GI motility. Okay. How about that? Okay. So majority of you answered correctly. There's some exceptions. C is the correct choice. Causes water absorption to the colon. It's a saline laxative. Milk and magnesia. Increase the osmotic pressure. Draw more water in the colon. Makes it more softer. Help passing it. It's not A, guys. Absorb water to increase bulk. Those are bulk forming laxative. Okay. That's an easy peasy one. Yes, A is the correct choice. At least 8 ounces of water. Perfect. Okay, how about that? Okay, well done. Yes, D is the correct choice, guys. It's an adsorbent. It binds to the bacteria and throw it out, flush it out. Okay. Let's look into this question. Okay, perfect. Yeah, D is the correct choice, guys. It can help reducing the level of ammonia. Okay. All right. Okay. Good job. Good job. Proud of you guys. Very well. A is the correct choice because it's a salicylate, and salicylate can increase the risk of bleeding. Good job. Okay. All right. We're done with this chapter. Any questions? Many, anything, guys? Anything at all?
This is off topic. This is about the critical thinking exam. So for the exam after class, do we stay on this Teams lecture, or do we take it on our own within the hour that we have?
No. It is proctored virtually, so we'll stay. What I'm gonna do is we're gonna use the office hours link. So we're gonna go off from here, the lecture link. So we are not making this recording too long that it takes forever to upload on YouTube. After the lecture for you to watch if you need to. So we'll use the office hours link. Okay, everybody understand that where are we gonna join?
Yes.
After the test, do we just leave?
Yes, as soon as you're done, you will leave. But before you leave, I want you to do one thing. As soon as you're done with that critical thinking assessment, I want you to download the report, that assessment report. You know how you guys after every module, like you download the report and then you submit it on Canvas, correct? So similar way, as soon as done and before you leave, please, I want everyone to do that. I don't want to see anybody that just stepped out and I know you might be in rush doing things, but I want you to do this before you leave. Download the report and then submit it on Canvas. Okay. Anything else?
How many questions are on this test? And is it ranked?
I can double check. I believe it's 40. Anyone else, guys? Any other question?
This test is just graded based off completion, right?
Yes.
Can you resend the office hour link?
Yeah, sure, I will. Anything else? No? All right, so it's 11:35. Let's come back at 11:45. Let's take a break. Thank you. Okay, welcome back, guys. Come back on. Turn your cameras on. Okay. So let's cover the third chapter, which will be the last chapter for the day as well. So, antiemetic, anti-nausea. Okay, so nausea, vomiting, that's what we'll be discussing in this chapter. And I do have a video to show you as well, which is quite helpful to understand this concept. So we'll talk about conditions as well as the drugs most commonly used, associated adverse effects, interactions, that kind of stuff, and important aspects when you're developing a nursing care plan. So let's watch the video first.
Going into an office, working 50 hours a week, having that structure.
Our topic today is medications used for nausea and vomiting. Nausea is the disagreeable feeling that often comes on before vomiting. Vomiting or emesis may be self-induced and voluntary, as with eating disorders like bulimia, or involuntary, as a defense mechanism, with a wide variety of causes. Some causes include chemotherapy-induced, postoperative, due to exposure to anesthetics, associated with disease processes, due to organ damage, or from exposure to a wide variety of harmful substances. Nausea and vomiting are also common in pregnancy, especially during the first trimester. Recurring emesis during pregnancy can lead to a dangerous condition known as hyperemesis gravidarum, where electrolytes and fluids get out of whack. This affects both the mother and the unborn baby. As you may have experienced, nausea and vomiting may also be precipitated by motion or seasickness. It can also be brought on by memories, odors, tastes, and sight. For example, seeing or smelling a cadaver, or getting a whiff of smelly feet. As mentioned, general anesthetics, especially inhaled volatile liquids, such as desflurane, are well known to cause nausea and vomiting in the patient after they wake up. This is known as post-operative nausea and vomiting, abbreviated PONV. Not only is this uncomfortable for the patient, but with vomiting, there is increased risk for tearing sutures, putting excessive pressure on organs, and increasing intracranial pressure. Remember that ongoing emesis will cause disturbances in electrolytes, fluids, and acid-base balance. Pregnant women, the elderly, and the very young are especially prone to developing these life-threatening imbalances. It's useful to remember that prolonged emesis is more likely to lead to alkalosis. This is due to the loss of acid from the stomach from all the vomiting. Conversely, prolonged diarrhea is more likely to lead to acidosis due to the excessive loss of bicarbonate ions in the feces. Remember that bicarbonate ions are made by the pancreas and secreted into the lumen of the small intestine to neutralize stomach acid. These bicarbonate ions are lost with lots of diarrhea. The control centers for nausea and vomiting include the chemoreceptor trigger zone and the vomiting center, both located in the brainstem. These two control centers receive afferent information from the vestibular system of the inner ear, gastrointestinal tract, and cerebral cortex. When these centers become activated, they release 5 main neurotransmitters, which bring about nausea and vomiting. These neurotransmitters include dopamine, serotonin, histamine, acetylcholine, and substance P. When the vomiting center is activated, it sends out efferent signals to elicit emesis. For example, it sends efferent signals to the salivary glands to increase secretion, and to the diaphragm to increase intra-abdominal pressure, and also to the muscles of the upper GI tract to reverse peristalsis. Together, these actions bring about the act of vomiting. Medications used to prevent emesis and nausea are known as antiemetics and anti-nausea drugs. Most of the medication classes used to prevent and treat nausea and vomiting act to block the effects of the elevated 5 neurotransmitters. The first is anticholinergics, which block the effects of elevated acetylcholine and include scopolamine, which may be administered as a patch applied behind the ear to prevent motion or seasickness. Trimethylbenzamide is also in the anticholinergic class. Serotonin receptor antagonists, more specifically 5-HT3 antagonists, like ondansetron, granisetron, and palonosetron, block the effects of serotonin release from endochromaffin-like cells in the gastrointestinal mucosa, as well as in the vomiting center and chemoreceptor trigger zone in the medulla oblongata. Indications for 5-HT3 receptor antagonists include preventing and treating nausea and emesis associated with cancer treatment, like cisplatin, radiation therapy, and for post-operative nausea and vomiting. Notice the generic names end in citron. It's a shortened version of the word serotonin. These medications are even more effective when they are administered with dexamethasone and aprepitant. Unlabeled uses for ondansetron include bulimia, alcoholism, and hyperemesis gravidarum. The next category is antihistamines and includes medications such as diphenhydramine, dimenhydrinate, and meclizine. These are especially useful to prevent nausea and vomiting related to motion sickness, and they also have anticholinergic properties to additionally block acetylcholine. There are a lot of NK1 receptors in both the CTZ and vomiting center. The ligand for this receptor is substance P. Aprepitant is selective for the NK1 receptor and blocks substance P. Aprepitant is used to prevent nausea and vomiting associated with cancer treatment and PONV. Anti-dopaminergic drugs like prochlorperazine, promethazine, and chlorpromazine are used for nausea and vomiting, as well as psychiatric disorders such as schizophrenia, and to treat intractable hiccups. One of the very useful dosage forms for these dopamine antagonists is suppositories. Like the antihistamines, these anti-dopaminergic medications also have anticholinergic properties. Metoclopramide has both anti-dopaminergic and anticholinergic properties. It is used as an antiemetic. It is also a prokinetic. That promotes gastric emptying into the duodenum, making it useful in the treatment of reflux or regurgitation. Long-term use of metoclopramide may lead to movement disorders like tardive dyskinesia. Dronabinol may be used when other medications don't work well. Dronabinol acts as a CB1 receptor agonist in the brainstem and gastrointestinal tract, and is also used to stimulate appetite in cancer and AIDS patients. Over-the-counter, abbreviated OTC, medications like Emitrol and nausea relief contain sugars like dextrose and fructose with phosphoric acid. These substances delay gastric emptying by reducing smooth muscle contraction in the GI tract. The same concept was used when your mom gave you 7-Up to settle your stomach. It's also important to know that the herbal remedy ginger is marketed for its anti-nausea properties. Notice the various locations where these antiemetics exert their actions. To summarize, nausea and vomiting can be caused by a wide variety of substances and conditions. These include reactions to certain odors, self-induced, overeating, emotional distress such as fear, motion or seasickness, food poisoning, infections, disease states, various injuries, organ damage, various types of pain, for example, from a kidney stone or migraine headache, chemotherapy and radiation, anesthetics, and many other medications, alcohol, and various harmful substances. It is also associated with pregnancy, especially in the first trimester. If it persists during pregnancy, it can develop into a serious condition known as hyperemesis gravidarum. Remember that ongoing emesis can cause dehydration as well as electrolyte and pH abnormalities. Pregnant women, the elderly, and the very young are especially prone to developing these life-threatening imbalances. The two control centers are the CTZ and vomiting center in the brainstem. Remember that they receive afferent information from the inner ear, gastrointestinal tract, and cerebral cortex. Also remember the 5 neurotransmitters that may increase with nausea and vomiting, including dopamine, serotonin, histamine, acetylcholine, and substance P. Remember the classes of medication for nausea and vomiting, including anticholinergics, 5-HT3 antagonists, antihistamines, antidopaminergics, prokinetics, NK1 receptor antagonists, CB1 receptor agonists, and phosphorated carbohydrate solutions. Notice that most of these are antagonists, except for CB1 receptor agonists and phosphorated carbohydrate solutions. Now for some questions. Pause the video and determine your answers.
Okay, so I hope I give you some basic clarity on nausea, vomiting, and what these medications are, different type of anti-nausea medications. So we're gonna just discuss in brief all those. So first of all, nausea, as I said, it's feeling of that uneasy feeling, a discomfort in the stomach, usually leads to vomit or your emesis. So that's a forceful expulsion of stomach content through the mouth. It could be triggered by various types of things, such as some GI disorders with food poisoning, gastritis, medication, any condition, motion sickness, pregnancy, as mentioned, or migraines or head injury. Those are the things. As far as the drugs associated, your serotonin antagonist, such as ondansetron, they end in cetron at the end. Cetron, ondansetron, Zofran, a very common one, which blocks the serotonin receptors. Then there are dopamine antagonists, such as metoclopramide, your Reglan. Then your antihistamine, such as Benadryl, diphenhydramine. Then your anticholinergic, such as transderm scope, the patch right goes behind the ear for motion sickness. Then cannabinoids, benzodiazepine, such as your lorazepam, that can be given as well. Okay. Now, if we talk once again about the reasons, okay. Nausea, it could be, acute, chronic. Acute is sudden and usually associated with food or medications, that kind of stuff. And it subsides as soon as the cause is taken care of. Then the chronic is more long-term conditions such as like gastroparesis or somebody has diabetes uncontrolled, that can happen. So it's an ongoing problem. Then chemotherapy-induced nausea vomiting is quite severe. Patient experience as they get the drug, either infusion or oral, and they experience that. And the best way to manage that is that to medicate them before they go for that treatment. Then motion sickness is very common. People going on cruise or hilly areas, they develop that. And it's also recommended that before they start that travel, somewhere 4 or 5 hours before they start that motion, which causes motion sickness, that you give them the medication. Then pregnancy related, that's more because of the hormonal changes happening, and most commonly happens during the first trimester of pregnancy. But if it extends and it becomes severe, that condition has to be monitored closely. Sometimes patient requires even hospitalization because of fluid and electrolyte imbalance, hyperemesis gravidarum. Then another common is after surgery, the postoperative nausea, vomiting, and you may see the transderm scope applied right behind the ear in those patients as well before they go to surgery. Now the drugs we just talked about, like anticholinergic, antihistamine, antidopaminergic, neurokinin antagonist, and all those. So let's talk about them. This was what listed on or shown in the video as well, the mechanism of action based on wherever the problem is, wherever the signal is coming from, wherever the trigger is for nausea, vomiting. There are 2 points right here, 2 zones, the chemoreceptor trigger zone, vomiting center in the brain, okay? So if the trigger is from GI, then prokinetic and serotonin blockers are good to use. If it's from the inner ear, because middle ear is associated with the balance, and that imbalance can cause the nausea, vomiting, anticholinergic, antihistamine, antidopaminergic, prokinetic can be used. And from cerebral cortex, the tetrahydrocannabinoids, corticosteroids, benzodiazepine can be used. So it's different targets based on whatever the pathway is causing the issue. That's what we target. Remember the classes, how they work, and some examples of it, such as serotonin antagonist. Okay, so ondansetron, the brand name Zofran, is the most common one. So know about that, that cetron, they end with cetron, ondansetron is an example of serotonin antagonist, and sometime you may see 5-HT3 receptor blocker or antagonist. It's the same thing. So they block the serotonin receptors in the gut as well as the CNS. And very commonly used for chemo patients, radiations, post-operative nausea. Until a few years ago, that was more common in your cancer patients, but now you will see this prescribed everywhere. Then your dopaminergic, most common, metoclopramide, which is Reglan. It blocks the dopamine receptor in the brain. Antihistamine, pick up an example of like your dimenhydrinate, maclazine. Those are antihistamine used for nausea, vomiting, and they block the histamine H1 receptor. For motion sickness, that's what it's most commonly used for. And then there anticholinergic, which is your scopolamine, which is transderm scope. The patch goes behind the ear for motion sickness or postoperative nausea. Your NK1, the neurokinin 1 receptor antagonist, example, your aprepitant, they block the NK1 receptors in the brain, which prevent the action of substance P, which causes nausea, vomiting. This is also used chemotherapy-induced nausea. Then your cannabinoids, such as dronabinol, very common. So it acts on the cannabinoid receptors in the CNS and reduce the vomiting. This is also used commonly in chemo patients. And then benzodiazepine in patients, either the patient's going for like chemo and they're anxious, and both things together makes their nausea vomiting worse and can be used. Then your corticosteroids. Corticosteroids can also, such as your dexamethasone, can also suppress the nausea vomiting in post-operative patients as well as chemotherapy-induced nausea. Any questions so far? All right, let's move on. Now we're going to go on the drugs, what are important in different classes. This is your transderm scope or generic scopolamine patch. What is important is first, which class it belongs to. It belongs to anticholinergic. And that should indicate that what kind of effect on the body when somebody takes anticholinergic. It's going to make your patient slow, sleepy, drowsy, dry. So drowsiness, slow, sleepy, drowsy, that is a safety risk. So they should not be involved in any activity which requires them to be alert, such as driving and stuff. Okay, that's a safety risk. Then, as it makes them slow, sleepy, drowsy, and dry, so means the secretion will be dried. What is the solution? More fluids, right? Now, what it's most commonly used for? Motion sickness. Motion sickness, somebody going on a cruise, you'll see this patch. It's a little tiny round patch, goes right behind the ear. Other important thing, this is good for 72 hours, means 3 days. This goes behind the ear for 3 days. And if they need more, well, then have to take that one, the old one off, clean that, and then put the other patch, new patch on the other side, not at the same side. This is also used in patients for post-operative nausea because they are given pain medication, they're giving anesthesia, which can put them at risk of nausea, vomiting after the surgery. So they place it before they go to the surgery, and so that by the time they're out, the drug is in their system to prevent that nausea, vomiting, and minimize it. Another uses in your patients on hospice or patient on hospice because they are on bed. The patient on bed, they experience a lot of issues. Simple things becomes complex because on the bed, while they have a lot of secretions, and those secretions sometimes kind of back up in the lungs, then they have trouble breathing and all that. And everybody around them, they have trouble breathing, and then the family, when they look at it, they are more concerned, like they're going through such a hard time. Then when you apply the patch, because it's a anticholinergic, which makes your patient slow, sleepy, drowsy, dry. So when there's too much secretion, because it makes them dry, it dries out the secretion and they can kind of breathe better. Make sense? So that's another use. Okay, now because it's an anticholinergic, you have to also make sure that you don't give it to patient with certain conditions which can become worse, such as male patients, BPH, benign prostatic hyperplasia, and they experience urinary retention. That itself is quite very uncomfortable. And if you give them this medication, from uncomfortable, it could be painful because they may experience even more urinary retention, more pain, as well as high risk of UTIs. So that is a problem. Then also with your patients, it could be male, female with bladder issues, okay, and they experience urinary retention as well. That is a problem. Another thing, remember what happens in glaucoma patients. Glaucoma patients, they have increased pressure in the eye or hypertension of the eye, or you called increased intraocular pressure, correct? So when these medications are given, it can increase the intraocular pressure. That is a high risk for those patients. So if somebody has glaucoma, it's a no-no. Okay? Everybody understood what is important from this drug. What do we need to know? Everybody okay? Can you guys repeat it? What is important about this drug? Just whatever you want to pitch in about. What just
Be careful with males for BPH.
yes.
It's common on patients on hospice and post-operative patients so that they don't have nausea.
Good job.
It's good
It
for
makes
3
someone.
days.
Oh, Vishal, go ahead.
Sorry, Alfred, go ahead. I cut you off.
That's okay.
Oh.
Vishal.
Okay. It makes you slow, sleepy, drowsy, dry. So tell patients to avoid doing certain activities.
Okay. Let's bring in more. What else, guys?
It works for 3 days, and then you would rotate on the other ear.
Mm-hmm. Good job.
Tell
What
the
else?
patient to increase fluids because of the slow, sleepy, drowsy, dry.
Yes, great. Anything else? Anybody want to add?
Don't give to a patient who has glaucoma.
Yes, excellent. And
It's
also
used for
don't
motion
mix it.
sickness.
Yes. And don't give it with anything else which can make them more slow, sleepy, drowsy, dry. Like, if it's with opioids, that's also could be a problem. Alcohol can suppress more CNS. That could be a problem, right? All right, good job, guys. Let's move on. Okay.
For that one, urinary problems are present in both male and female, right? Or was it just males?
It could be both.
Could be both. Okay.
But the problem could be different shape, different, like, BPH in males and females may have different problems with the bladder and continence and stuff. Okay. Now, antihistamines. Remember, antihistamine does the same thing, right? Slow, sleepy, drowsy, dry. Same issues with that. The mechanism of action, while they block histamine receptor, which one? H1. H1. And this can also be used in motion sickness. Okay, motion sickness, vertigo, like your hydroxyzine, is your dramamine, maclazine, diphenhydramine, which is, Benadryl. Yeah. Here's your anti-dopaminergic. Anti-dopaminergic. They block the dopamine receptors. Dopamine receptors. Now, what do dopamine receptor do? Well, they release what? Dopamine. And if you're blocking them, what is gonna reduce? Dopamine, correct? Now, what does dopamine does? What is the use dopamine? Buddy. In these patients, especially older, you may see confusion and you may see, issues with the body movement, like, the that they're walking like not
Disorient.
normally, the gait disorders, right? That they are not able to control their body movements effectively. Okay. So they block the dopamine receptors. Metoclopramide. So metoclopramide is a high risk in older patient population. So just remember that. Then promethazine is also, it can make your patient more slow, sleepy, drowsy, dry. That is important. Okay, now let's talk about this metoclopramide, your prokinetic thing. Metoclopramide, which is Reglan metoclopramide. This drug could be a problem with your older patient population. Okay, older patient population could be at a high risk. Now, first of all, how does it work? What is the mechanism of action? As the name says, prokinetic. Kinesis means the movement. Pro, their supporter. So they promote the movement. Okay, where? In the GI tract, and it increased the GI motility. So they help to move the mood through the food through the stomach and intestine more effectively. Right? So they block the dopamine receptors and enhance the acetylcholine activity here. Promote gastric emptying, increasing the lower esophageal sphincter tone. Used in gastroparesis and nausea, vomiting. And then there are like others like domperidone, and in some patients, you may see an antibiotic erythromycin as well in a very low dose. Okay, but it's not common practice. Okay, so once again, in older patient population, it is important, okay, it's important that it can cause movement disorder, usually it's called tardive dyskinesia. Okay, tardive dyskinesia. So that is important to know because it puts your patient at risk. And here is one real important class, your serotonin blockers. They're also called 5-HT3 receptor blockers. 5-HT3 is serotonin. So they're serotonin blockers for nausea, vomiting. So mechanism of action is in the name itself. They block the serotonin receptor. They are in the CTZ, the chemoreceptor trigger zone in the brain. And they're also present in GI tract. Okay, how do you identify them? They end with cetrone, and ondansetron, which is your Zofran, the brand name, is the most commonly used. So we're gonna focus on that. Now, if that's what your patient are most commonly used, or you'll be giving most commonly to the patients, you need to know, is there any common adverse effect associated with that? Okay, so please write that down as well. The ondansetron, Zofran, has a common adverse effect, headache. Patients experiencing headache. Now, why it's important to know? Reason is that lots and lots of patients, when we say most common, means a lot of patients are going to experience headache. So we should inform them, let them know that, hey, this happens commonly. So if you experience headache, that is a known adverse effect associated with this drug. But is it concerning? No, unless it's severe. It should go away after a little while, but they should know. Okay, this is commonly used. I mean, previously was more towards chemo-induced nausea, but now it kind of any kind of nausea, even you will see these prescribed to kids these days. And that was not the case 10 years ago. It's completely different. It used to be very expensive, but not anymore when it was brand only. Okay. Now, along with your prescription or some OTC meds, there are some OTC non-meds products as well, such as your like ginger and stuff, peppermint that can be used as well to some extent. It may not be helpful to everyone, and not to the extent if the severity is high, but to some extent they do help. So ginger. So it also kind of modulate the serotonin receptor in the gut and reduces the stomach motility. So it can be used in nausea, vomiting because of motion sickness, morning sickness, or post-operative nausea. It can be used, but this can cause excessive use can cause like heartburn, and also in your older patient population who are on blood thinners or has risk of bleeding, that could be a problem for them. Okay. Then as far as peppermint, peppermint has kind of a more calming effect on the stomach muscle and improves the flow of bile, which can help in digestion. So this can be more commonly, could be used in nausea due to indigestion. It could be in the form of tea or capsules or, you know. Then another thing is vitamin B6, pyridoxine. Okay, this is especially used in pregnancy, the nausea in pregnancy. Vitamin B6, pyridoxine is also helpful when pregnant patients, they experience the morning sickness. Okay. And then there are other products such as, some, I don't know how effective they are, like acupressure brands and all kind of stuff. Not sure how well they can help. But whenever you're giving these medication, make sure there's no interaction, especially as I mentioned with like garlic and stuff. It can increase the risk of bleeding if patients are taking blood thinners and anticoagulant stuff. Okay. Now, as a nurse, important, assess your patient. What is the reason, potential reasons? What do they take? Is it the medication can cause that or something else? What do they eat? What did they drink? How long it's been happening from? Has it happened before? What did they take? Did anything help? Did they take anything now? All kind of information you can dig as much as you can, you should. Then look for potential solutions, and before you provide them a solution, make sure they are safe. Are there any contraindication because of the drugs they're taking, OTC, herbals, supplements they're taking, or with their diet, all kind of stuff? Make sure it's safe to give. Okay. And as I mentioned earlier, some classes can suppress the CNS, and making sure we do not give it with anything else which can increase that risk even more. And these antihistamines are known to make your patient slow, sleepy, drowsy, dry. And if you give it with something which suppress CNS even more, that is a high risk for these patients, especially too young and too old. And if they are taking medication belong to those classes which suppress the CNS, safety is a big concern, and it's important that we educate them about safety as well. And no driving. Okay. Any questions so far? Any question? No? You guys are real quiet. Sometime I have to look at your faces. Okay. Yes, you guys are blinking. Yeah, you are awake. Okay. Too quiet, too quiet. Okay. I know that guy. I understand that I torture you guys too much and throwing all kind of stuff on your head, and yeah, it drains you out. It's a lot of information, but just stay focused. What week we are in? There you go. Six. How many left? 2. 1 plus 1, 2, right? 1 plus 1, 2. Isn't that short? We covered more, right? We covered more. Just a little more to go. So stay awake. Keep pushing, keep pushing, keep pushing. Cross out the day every single day. One less day to go. You're almost there, almost there. But it's like life and death, okay? Put up everything you have now. It is critical. That's what is going to determine. It's like, somebody just dropped you, gave you parachute and see like if you can open it on time or not, right? So we are there now. We're just near the landing zone. We need to open it up now. Okay. Let's do some questions. Let's see what Super Nurses has to say. Okay, good job, Olga. Okay, Bella, yes, good. Does everybody know how does it work? So this is an anticholinergic, right? It's an anticholinergic. So the name tells you they are against the cholinergic action. So what do they block? The acetylcholine at the cholinergic receptors. Correct? When you block that acetylcholine from binding to these receptors, the signals which induce nausea originating in this area cannot be transmitted to the chemoreceptor trigger zone. And what patient teaching will the nurse provide about the use of patches? Okay, yeah, slow, sleepy, drowsy, dry, right? Slow, sleepy, drowsy, dry. So whatever is associated with slow, sleepy, drowsy, just open that up to the lady, right? So do not take it with anything else which makes you more slow, sleepy, drowsy, dry. What is the potential risk there? That lady going on the cruise. What can she probably take there which can put her at risk?
Alcohol.
Yeah, going on cruise. The lady may not like you, but you gotta tell her, right? No? And she gonna tell everybody on the cruise, oh my goodness, I don't like that nurse. She just told me you can't have alcohol, right? All right, all right, all right, all right. Okay, so any question on this question, about this question, guys? Is everybody clear about the question as well as the answers? Yes. Okay. This one, I'll explain this in a little detail. In a patient pregnant, experiencing unrelenting nausea, vomiting, causing significant dehydration. Remember the condition you said in the first trimester, hyperemesis gravidarum. That's probably going on. So she's hypotensive, the blood pressure drops. And tachycardia, now the blood pressure dropped, they are dehydrated. When your patient is dehydrated and the blood pressure dropping down, now the heart will beat faster to compensate that. That's why they're tachycardia, right? So what medical management is indicated? Now, number one is we know pregnant. The condition itself is high risk. Now they're losing fluids. Along with that, electrolytes. Not only the patient at risk, even the fetus. So first thing, replenish the fluids. Okay. And in usual circumstances, you will give them oral, but she's pregnant and hyperemesis gravidarum means she's throwing up all the time. And she is probably may need hospitalization at that point, and you need to start an IV. She won't be able to keep it at that point. Maybe a later, and you need to give her like, Zofran, ondansetron, but, initially you have to start with IV. Okay, so IV replacement to give her the hydration, the fluid, that is important so that you can increase her blood pressure, right? The heart rate to normal, and then you're giving her Zofran. Now, what would the nurse include in patient education regarding treatment of hyperemesis level? First of all, she should be on bed rest, okay? And then because this puts her at risk of hypotension, then safety precautions like, sit at the corner of the bed before standing, okay? To prevent the falls due to postural hypotension. And then also, you can suggest like ginger tea, peppermint to decrease nausea. And then vitamin B6 can also be used. Okay. Okay. How about this next question? The chapters we are doing today, they're not hard, but again, you have to make sure that you organize them based on their mechanism of action and then write down the common drugs under that and any adverse effects, those kind of things, something important you need to memorize. Don't just try to read and memorize. Please organize them. And like example would be, for example, if you're using anticholinergic antihistamine, all of them, no matter whichever it is going to make your patient slow, sleepy, drowsy, dry. Whatever the mechanism of action under that class, it's going to be same. Same with serotonin receptor blockers. Okay, so you answer D, which is correct. Serotonin blockers, they end in cetrone, ondansetron. So that's